Hello, my name is Pedro Fioni and I'm going to talk about a summary of the virus. First, we have the definition. Current standard immunotherapy for renal cell carcinoma includes nivolumab plus ipilimumab, axitinib plus pembrolizumab, abelizumab plus pembrolizumab, and high-dose interleukin-2. Ongoing phase 3 trials are comparing the combination of tyrosine kinase inhibitor plus a checkpoint inhibitor. Hepatitis E is a liver disease caused by the hepatitis E virus. The virus has at least 4 different types: genotypes 1, 2, 3, and 4. Genotypes 1 and 2 have been found only in humans. Genotypes 3 and 4 circulate in several animals without causing any disease and occasionally infect humans.
Hepatitis E is RNA virus. Spread by the fecal oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you for watching.
Application medicine. Cytokines regulate the innate and adaptive immune response. Based on the proven efficacy of high-dose interleukin-2 in renal cell carcinoma, researchers are combining cytokines with checkpoint inhibitors. The antiviral drug ribavirin can clear chronic hepatitis E virus in solid organ transplant recipients, researchers reported.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure.
Pros and cons. For pros, we have ribavirin is a general antiviral that inhibits replication of many RNA and DNA viruses. Durable and complete responses show the true potential of immunotherapy, which is the ability to cure patients with advanced renal cell carcinoma. And the cons, we have that durable and complete responses show the true potential of immunotherapy, which is the ability to cure patients with advanced renal cell carcinoma. And the optimal dose of ribavirin for the treatment of chronic hepatitis E remains to be determined as treatment failure may occur.
So now let's meet some patients so we can put to work what we have learned about hepatitis E diagnostics. Our first patient is Hannah. She feels sick and had to vomit at home. She's feverish and her skin has a yellowish color. Her symptoms started 1 week ago. 4 weeks ago, she came back from Mexico when she visited family. Obviously, we think about hepatitis. Let's order lab tests. In Hannah's lab report, we can see that her liver enzyme function is significantly elevated. Furthermore, her hepatitis E tests are positive. Hepatitis E RNA is also detectable. So what's your diagnosis? Hannah has no history of immunosuppression. So let's take a look back at the graphic dealing with immunocompetent patients. Her ALT is very high, which signifies serious liver damage. Anti-HEV IgM and IgG are both positive, and we could detect RNA in Hannah's stool. Based on these results, we can conclude that Hannah is most likely in the early phase after infection. So Hannah is suffering from an acute hepatitis E infection. Let's see our next patient. Our second patient is Pete. He suffers from abdominal pain of recent onset. In the lab report, we can already see elevated liver enzymes. Pete received a lung transplant 8 years ago. Currently, he is on immunosuppressive therapy. Furthermore, he tells us that he's a passionate hunter. Based on Pete's history, we include hepatitis E screening in our lab report. We can see that his liver enzyme function is significantly elevated. His anti-HEV antibodies are negative. However, the lab detected HEV RNA in Pete's stool. What does that mean? Since we know that Pete is taking immunosuppressive medication, we should consider this in interpreting his lab results. We know that immunocompromised patients can have problems producing antibodies to the virus. So in Pete's case, it is essential to measure RNA. His lab report shows elevated ALT levels as a sign of liver damage. But
Issue applied in Ecuador. In Ecuador, there is not yet this kind of treatment since he's still in phase 3. Trained doctors will when treatment arrives in Ecuador. That's the issue about these diseases.
I think the most interesting data and the one that people are very excited about is the eMotion 151 that we just heard from Dr. Bob Moser. And this is a phase 3 randomized trial that looks at bevacizumab with atezolizumab versus sunitinib in a phase 3 setting for advanced metastatic clear cell kidney cancer. So let me just give you a little background on how we treat kidney cancers or advanced kidney cancers. So certainly there has been a lot of landscape changes. In the past, if we go back even a decade ago, we really did not have a lot of systemic therapies to offer. But now we have VEGF inhibitors, so these are what we call the TKIs. And certainly we have the immunotherapy drugs, but mostly for second line right now. So with the advent of these trial, the landscape of treatment is really changing. So,
and for the last, we have the conclusion. This retrospective multicenter study showed that ribavirin as monotherapy may be effective in the treatment of chronic HIV infection. A 3-month course seemed to be an appropriate duration of therapy for most patients. Immunotherapy with checkpoint inhibitors is now considered a standard of care for the frontline treatment of advanced renal cell carcinoma. Despite better outcomes with these agents, there is still room for improvement.
Sunitinib is a standard first-line treatment for kidney cancer, but it's becoming decreasingly used in the first line. For these intermediate and high-risk patients right now, it's probably not the standard of care. The standard of care at Columbia and at other places, actually especially academic places, is combination immunotherapy with anti-PD-1 and anti-CTLA-4. So whether you get the same result with modern immunotherapy or not is a very good question, actually. The other thing is I can tell you that there have been preclinical studies and now clinical studies suggesting that you should give immunotherapy before surgery. There was a recent paper in the New England Journal of Medicine from the Hopkins Group showing that in lung cancer, giving immunotherapy before surgery is much more efficacious than giving it after surgery. We don't know whether that's the case in kidney cancer or not, but we do know that sunitinib in the adjuvant setting after surgery has generally not been helpful, actually. So the question is, if we gave immunotherapy before surgery and compared that to immunotherapy alone, what would be the readout? That is being tested to some degree in an ECOG trial at this point with nivolumab monotherapy. But it is an important question. Again, the two things are, if it was a different drug, if it was real immunotherapy, or if it was neoadjuvant treatment was applied, would still have the same result.
Thank you.